organized by the Oncology Club of Bangladesh. Today is our tumor board sessions, and topics are the today's are the endometrial malignancy and the ovarian malignancy. Before starting the session, I would like to request our chairpersons of the today's session, Dr. Professor M.A. Haisar, to tell about something about today's sessions and give us permission to start the session. Sir, please.
Thank you, Dr. Shana. Bismillahirrahmanirrahim. Today we have tumor board, endometrial ovarian cancer. We have today our foreign faculty, Dr. Bafna, Dr. Abraham, Dr. Bhavna, and Dr. Santosh, all from India. And our local friend today is Rumana Afroz and Arif Najmunna. Without any delay, we should start immediately, already 10 minutes late. Thank you, Nana. Start soon. I'm going to start.
मैम आपका म्यूट करा
Our foreign faculty today are Professor Dr. U.D. Bapna sir. Sir is the professor and head Department of Gynecological Oncology, BM Join Hospital, Bangalore, India. Dr. Abraham Pedicel sir. Sir is the senior consultant Gynae Oncology, Sultan Qaboos Comprehensive Cancer Center, Muscat, Oman. Dr. Bhavna Rai. She is professor, Department of Radiotherapy, PGIMER, Chandigarh, India. Dr. Santosh Menon. Sir is the professor, Department of Pathology, Uro-Oncology and Gynae Oncology, Tata Memorial Hospital, Mumbai. Our today's local faculty are Dr. Rumana Afroz. Rumana Afroz, resident Gynae Oncology, National Institute of Cancer Research and Hospital. Another one is Dr. Sharif Nadhun Nahar. She is also the resident in Gynae Oncology, National Institute of Cancer Research and Hospital. And we have more other faculties today. Those are the Dr. Supriya Chopra. She committed to attend the 2 days program. She is the Professor, Department of Radiation Oncology, Tata Memorial Center, Mumbai. And Dr. Zahid Khan, he is Consultant Medical Oncology, Chatterjee Cancer Center, Liverpool. And with us, Dr. A.F.M. Kamaluddin. Dr. A.F.M. Kamaluddin, he is the Scientific Secretary of the Oncology Club, and Dr. Professor A.M.M. Shariful Alam, sir is the General Secretary of the Oncology Club, and the man who is always with us, Dr. Professor A.M.A. Haisar, sir is the President of the Oncology Club, who is our inspirator. Thank you all for being with us. Now I request, before starting our original session, I request our Mr. Mahabub to show the poll questions first. At first show the poll questions, then we will go our original session. Mahabub, please show the poll question, please.
না কোশ্চেন গুলো তো কমপ্লিট হয় নাই, ইনকমপ্লিট রয়ে গেছে অ্যান্সার গুলো।
ম্যাম ডান।
Sir, okay, thank you, sir. Now I first request our first presenter, Dr. Rumana Afros, to present her case. Her first case, Dr. Rumana, please.
Thank you, madam. Is my screen visible, madam?
Yes.
Honorable Chairperson, distinguished foreign faculties, respected teachers, and learned participants. Assalamu alaikum. I am now going to present first case of this tumor board session. This patient is a 55 years old menopausal diabetic lady with 4 living issues. She consulted a local gynecologist in a peripheral hospital in March 2021. Her complaint was postmenopausal bleeding for last 2 months. Transvaginal sonography was advised, which showed cervical mass with thickened endometrium with endometrial collection. Size of the mass and thickness of the endometrium was not mentioned. So my question is, this is a case of postmenopausal bleeding with cervical mass and thickened endometrium. Sorry, what should be the evaluation method in low resource setting like Upazila or district level?
Bapna sir, please.
Okay. This patient with postmenopausal bleeding of 2 months duration has got cervical mass as well as endometrial thickening on TVS scan. So
Yes.
I think as soon as the patient comes to you to the clinic, you could do an endocervical biopsy and follow it up with endometrial biopsy. So you can take 2 biopsies, endocervical biopsy first, then you can take endometrial biopsy. So that by pathological examination, you should be able to differentiate between cervical cancer and endometrial cancer. So you'll have to do some more ISC markers. The pathologist has to do some ISC markers. Most importantly, P16. If P16 marker is positive on immunohistochemistry, the diagnosis would go in favor of cervical cancer. If P16 marker is negative on pathological examination, then probably you are dealing with endometrial cancer.
The patient is in a peripheral hospital, Upazila level, so
Or a district hospital in that
district
area.
hospital. Yes, sir.
And very poor.
Okay,
In that
you
case,
don't have to do P16 in a rural area or a smaller town, because if you take a biopsy from the cervical mass and the endometrial mass, if the biopsy shows endometrioid carcinoma, which is the commonest endometrial cancer, then you treat them like endometrial cancer. On the other hand, if the biopsy report comes as squamous cell cancer, then you have to treat them like cervical cancer. So plain histopathology, conventional histopathology is good enough to differentiate between a cervical mass, cervical cancer and endometrial cancer in most patients. When you have a case of adenocarcinoma, which is not specified whether it is endometrioid or not, then I think probably you have to do some more IHC markers to differentiate between endometrial cancer from cervical cancer.
Thank you, sir.
so what is before, at least in peripheral area where only the minimum investigations available, in that cases, minimum we can do, if we do the biopsy, there are 2 areas in these cases where there is the endocervix, cervix is enlarged and big enough, and also the endometrium is thickened. So we should take the 2 samples, one from endometrium and another from, at least another from endocervix. Okay, sir. Thank you, sir.
Yes.
Thank you, sir. Unfortunately, patient underwent total abdominal hysterectomy in that private clinic on 5th March 2021. Preoperative evaluation was not done in this case, and histopathology of resected specimen was also not done. Patient had no complaints till 2 months after surgery, but patient again developed parvaginal bleeding 2 months after surgery. Biopsy was then taken from vault. Tissue from vault mass showed biphasic malignant tumor containing carcinomatous component of glandular type and sarcomatous component, and report was mixed Mullerian tumor. With this report, patient was then referred to NICRH. On examination, patient performance status was 0, no lymphadenopathy was there. Other parameters are normal. In pelvic examination, it was shown that cervix was visible and there was an exophytic growth involving both lip of cervix measuring 3 into 3 centimeter. Anterior and left fornix was involved by the growth. Tissue was taken for biopsy from cervix, and biopsy from cervical tissue was showed spindle cell carcinoma. Then slide review was done, which showed carcinosarcoma. So how to differentiate between these two histopathology? And will this vary treatment plans in these two types of histopathology?
What are the two histopathology? One is carcinosarcoma.
One is carcinosarcoma and another is spindle cell tumor.
Spindle cell tumor. Okay. I think the person, the pathologist who has seen the slides has seen the spindle cells. That could be due to sarcomatous element. Probably they have missed the carcinomatous cells. So most probably this is going to be carcinosarcoma, because pure sarcoma as such is quite rare. So most probably I think we are dealing with carcinosarcoma as seen in the second report, which was carcinosarcoma. Now I think since patient has undergone incomplete surgery, the cervix has been left behind. So that means there is a possibility that the surgery was done through the tumor. During hysterectomy, the body of the uterus was removed separately and the cervix was left behind. So there is a possibility of intra-abdominal spillage and intra-abdominal spread of the tumor. So now she comes to you with vault or cervical recurrence. So you'll have to investigate her thoroughly to rule out any metastasis in the pelvis and abdomen, and also in the distant regions.
Coming, sir.
Thank you, sir.
Our question is there any treatment modalities varies whether it is spindle cell tumor or carcinosarcoma? Okay.
Yeah, carcinosarcoma has got a different treatment compared to sarcoma.
No,
Sarcoma, I think, pardon?
Sir, one by report showed the spindle cell tumor and another report showed the carcinosarcoma. Is there any variation between these two for treatment, getting the treatment?
No, I think you have to be very, very specific whether you are dealing with spindle cell tumor or whether you are dealing with carcinosarcoma. Spindle cell tumor, I think most probably it could be sarcoma. So what kind of sarcoma? Is it leiomyosarcoma or is it endometrial stromal sarcoma? I think we need more specific diagnosis.
Okay, sir. Next.
Thank you, sir. So immunohistochemistry was done to differentiate between these two. This showed vimentin positive and cytokeratin positive, and which confirmed carcinosarcoma. As immunohistochemistry showed vimentin positivity, is it indicate endometrial origin?
Abraham, sir. Abraham, sir, join.
Yeah, sorry, I'm a little late. I'm not sure what sort of tumor we are dealing with. Is it carcinosarcoma of the uterus or cervix or?
We don't know, sir. She has subtotal hysterectomy outside our institute, and our institute she attended with a mass in the cervix. We don't know whether it is the endometrium or it is the cervix. Only we got the cervix.
But was there tumor in the uterus?
We don't know because we didn't get the uterus.
Histopathology was not done when
Not done
hysterectomy
during
was
that
done.
time.
Oh my gosh. So we're really in the dark now.
Yes.
I mean, carcinosarcoma of the uterus is more common than carcinosarcoma of the cervix.
Before sir, at first she attended with a private clinic in a Upazila health complex with a complaint of postmenopausal bleeding, and with that she only transvaginal ultrasound done, and transvaginal ultrasound findings was endometrial was thickened and mass in the endocervix. With this, subtotal hysterectomy was done and no histopathology report during that time. And again, when her symptom persist, she was referred in our institute.
Then biopsy from cervical growth showed carcinosarcoma.
I don't think it will matter whether the origin is from the endometrium or from the cervix, because he has undergone subtotal hysterectomy.
Yes, sir.
So whether it is coming from the body of the uterus or whether it is coming from the cervix, the carcinosarcoma management would remain the same.
Okay, sir. So we need not differentiate the origin, whether it is cervical or endometrial.
No.
Okay, thank you, sir. Is carcinosarcoma of cervix HPV associated, or it is not associated with HPV?
No, I don't think so. I'm not very sure. I don't think carcinosarcoma is associated with HPV infection, but I'm not very sure.
Okay.
Abraham, any idea, Abraham?
No, I mean, there are associations, but whether it is causal or not, we're not sure. I mean, HPV may be found. There are reports where carcinosarcoma of the cervix, there is HPV 18 and other types, but not it's much more common to find the other types other than 16 and 18. But whether it is causal or not, we're not sure.
Okay, thank you, sir.
Now, is the parametrium infiltrated or is it freely mobile, the cervix?
No, sir. It is parametrium. It was thickened and infiltrated to parametrium.
So then, how are we going to treat her now?
Yes, next.
Chemotherapy followed by radiation, or?
No, sir. No, parametrium was thickened, not the whole the parametrium was involved. This we are going. Next. AK, have you any, do you like to comment about this carcinosarcoma? If it is SPV, is it SPV associated? AK? Mahfuz?
Ma'am.
Sorry, yes. Thank you for the conversation. It's a very wonderful conversation. And just to reinforce, it is unfortunate she did not get preoperative biopsies. My one thought in terms of the preoperative biopsies is you could have also done a small leap to get stroma, to look for stromal invasion. So just those comments about that. An undifferentiated extension or dedifferentiated extension of adenocarcinoma from the endometrium. So in general, it's a sort of combination of two sort of clonal cells that originated before it got dedifferentiated. I don't think it's associated with HPV. I'm very curious how you treated this poor unfortunate woman. I'm sure we will hear about that in a minute. Thank you.
Thank you, madam. So as patient was poor, the pelvic MRI was advised to evaluate her, and pelvic MRI with upper abdominal screening was done, which showed a vault mass 3 into 5 into 4 centimeter. Upper 1/3 of the vagina was involved by the growth, and no lymphadenopathy was in MRI. In this case, as carcinosarcoma of cervix is aggressive, and before there was a subtotal hysterectomy, so other advanced imaging like CT scan whole abdomen should be done, needed before planning treatment.
Yes, definitely. I think this patient should have thorough investigations because she has had subtotal hysterectomy. There is every possibility of tumor spillage during subtotal hysterectomy. So you must rule out pelvic and abdominal metastasis, at least by doing an MRI scan of abdomen and pelvis with IV contrast. Or if patient is able to afford, you can go for FDG PET scan to rule out any extra-abdominal metastasis as well. If you do not have a facility for PET scan and if you do not have a facility for MRI scan, so it's not a bad idea to do a contrast-enhanced CT scan of abdomen and pelvis. So thoroughly, you must have at least a CT scan before proceeding with the further treatment.
In this case, pelvic MRI and upper abdominal screening was done, and upper abdominal screening showed no metastatic deposit. So CT scan is not done. Now, what should be the treatment of carcinoma cervix post subtotal hysterectomy?
No, the MRI scan has not commented upon the involvement of the parametrium and whether there is a plane between the bladder and the cervix or not, whether there is a plane between the rectum and the cervix, and shows involvement of upper one-third of vagina. So clinically, the vagina was free. I mentioned that the tumor was arising from the cervix.
The parametrium seems to be not involved in the image.
But clinically, vagina also was free.
Clinically, fornix was involved, sir.
Involved, but upper vagina was free.
Upper vagina, yes, sir.
Okay, okay.
He definitely needs upper abdominal imaging because it's carcinosarcoma. We have to image upper abdomen and probably lungs as well.
Thank you, sir.
Has she had any upper abdominal imaging and thoracic imaging?
She had done chest X-ray, which was normal, and upper abdominal screening of done, MRI, pelvic MRI with upper abdominal screening was done, but not CT scan whole abdomen was done.
And how long ago was the subtotal hysterectomy?
It was done in March 21.
I think she probably needs a PET scan. Because so once you have cut through tumor, it can spread quite rapidly.
Yes, sir.
I don't think we can assume that it's confined to the pelvis.
Thank you, sir.
Okay.
So now what should be treatment in this case? Carcinosarcoma cervix post subtotal hysterectomy and apparently confined to pelvis.
I think the treatment has to be individualized here because even though the cervical tumor is confined to the cervix, but the tumor is quite large. Okay, so it is possible to do surgery right now, and you can excise the cervix. Along with the excision of the cervix, you can also do the other staging procedures, like you can do pelvic lymphadenectomy and aortic lymphadenectomy along with the ventrectomy. And you must also inspect the abdominal viscera for any metastasis. And if there are any metastasis, all those metastases should be excised. So this is one option. If you are comfortable and if you are clinically, if you are sure that you can remove the cervix without injuring the urinary bladder and without injuring the rectum, then you should go ahead with surgical excision. Remove the cervix, do a ventrectomy, do retroperitoneal lymph node dissection, and if there are any deposits in the peritoneal cavity, all those deposits should be removed. After the surgery, you have to plan for adjuvant therapy.
Okay, sir. Thank you, sir.
Next.
What are options if this was an inoperable case? This case,
Dr. Bhavna.
Yeah, okay.
Yeah.
So if this is an inoperable case, we would want to go in for chemotherapy upfront because like Dr. Bafna and Dr. Abraham has already mentioned, these are the diseases which tend to throw metastasis. And this has been an incomplete surgery, which has been a cut-through surgery. So definitely she needs systemic control and followed by local pelvic radiation. And I don't think external radiation would be sufficient for her. She would have to be boosted with some form of brachytherapy thereafter. So it has to be a combination of chemotherapy followed by radiation.
okay, thank you, madam. Trachelectomy, parametrectomy, upper vaginectomy, bilateral pelvic and para-aortic lymph node dissection with omental biopsy was performed in 23rd August 2021 at NICRH. And paraoperative finding was there is a growth in endocervix 3.5 into 2.5 centimeter Multiple pelvic and para-aortic lymph nodes are dissected. Among them, 1 enlarged pelvic node in right side and 3 enlarged lymph nodes in left side, and para-aortic lymphadenectomy was also done. And exploration of abdominal cavity seems to be no metastatic deposit was found there. This is specimen, cervix with growth, omentum and lymph node. This is our final histopathology report, which
Sorry
showed.
to interrupt here.
Okay, thank you, sir. Yes,
I
sir.
would like to differ here. Should not be happy with only omental biopsy.
Okay.
You have to do a total omentectomy. Total omentectomy is preferable because there could be occult metastasis in the omentum. So you have to do not only infracoelic omentectomy, it's better to do a total omentectomy because the tumor has been spilled during the first surgery. So we don't know where the tumor is, where the macroscopic tumor is. So the omentum is the first site which picks up the tumor. So omental biopsy may not tell you adequately whether the tumor is spread to the abdominal cavity or not. It's better to do a total omentectomy.
So why we don't do for the peritoneal biopsy? We don't know where it is metastasized.
Correct. That's why better to go ahead with do total omentectomy, or at least you must do an infracoelic omentectomy. If you are not comfortable with total omentectomy, you must at least do complete removal of the infracoelic omentum from the splenic flexure to the hepatic flexure.
Yes, I would also agree with that. At least, you don't have to go up to at least up to the arcade you must remove. If there is no visible tumor, probably you don't have to go up right up to the greater curvature, but at least up to that arcade of the greater epiploic vessels. And also multiple peritoneal biopsies.
Yes, sir.
Thank you, sir. So now this is final histopathology report in our hand, which showed size of the cervix was 7.37 into 3 centimeter. This is not the measurement of growth. This is only the measurement of the cervix, which is enlarged by growth. Malignant neoplasm composed of both carcinomatous and sarcomatous component, which means it is carcinosarcoma. LVSI is present. Ovaries, both-sided ovaries and fallopian tube showed free of tumor. Omental tissue was free of tumor. Vaginal resection margin was free of tumor, and pelvic and para-aortic lymph node show reactive changes.
So was there tumor in the pelvic node?
No, sir.
No, sir. Pelvic and para-aortic lymph node showed reactive changes.
Was a peritoneal cytology done?
Yes, peritoneal cytology was done and it was negative.
Report was lost, so I could not show it, but it was negative.
You would anyway require chemotherapy because it's carcinosarcoma. And then Bhavna wants to give radiation also.
So adjuvant therapy in this case.
Bhavna,
ma'am.
Yes, definitely upfront chemotherapy. And in this particular case, just because there was a big growth at the cervix, we should give her pelvic radiation.
So chemotherapy followed by pelvic radiation?
It should be given.
There is a chance of recurrence in this case is high. So this patient should be followed up as usual CA cervix patient, or there should be more frequent follow-up?
I'm not sure if we can still have a diagnosis of CA cervix. I mean, I would want to even have an opinion of others. I probably think this is a CA endometrium with cervical involvement.
No, her question is, as it is carcinosarcoma,
yes,
the chance of recurrence is more.
Definitely.
So what will be her follow-up protocol? Either the cervical carcinoma or endometrial in that, or the more frequent follow-up?
No, the follow-up will remain the same.
Once in 3 months should be fine, but only thing we should do CA-125 in her case.
So in each follow-up, patient should do CA-125?
At least once in 6 months, I think.
Once in 6 months. Okay, sir.
CA-125, what was the initial value?
Initial value, sir?
Was it done?
CA-125 was not done, sir.
Okay, if it was done, then we would have had some idea. Now, without having any CA-125 report, I think you can still do CA-125, but it may not be very useful.
Okay. Yes, sir.
No, it will pick up any peritoneal spread. If there's any metastasis in future, we might pick it up.
Okay. Yes, sir. And what about imaging, sir? When, how frequently she should do imaging?
Bhavana?
For these kind of patients,
Yes.
for the first imaging we do is at 3 months follow-up.
What type of imaging that at 3 months follow?
Yes, and then subsequently we do it as and when we suspect a recurrence.
Yeah.
Okay.
If-
Thank you, ma'am.
With only ultrasound or in advanced imaging?
No,
CT,
we
MRI?
go in for a CCT chest, abdomen, pelvis as a basic minimum investigation.
Yeah, at first after 3 months.
Yes, and as Dr. Bafna and Dr. Abraham have said, we would even want to get a CA 125.
Yes.
Thank you, ma'am.
Sometimes the patients, they are not capable to do this. They are, and always they cannot afford this, doing the CCT chest, abdomen and pelvis. In that cases, what can we do?
Minimum of an X-ray chest and an ultrasound abdomen and pelvis.
Yes, yes, because they're getting the treatment free of cost in government hospital. And there only they can do the ultrasound and only the chest X-ray. Even for the CT scan, they have to pay something.
Yes, I think a good ultrasonography scan of abdomen and pelvis is good enough. You don't have to do CT scan in all the cases at all the places. Depending on the resources, I think a good ultrasonography scan of abdomen and pelvis should do.
Yes, sir. Thank you, sir. So in this case, if recurrence occur, then what will be her treatment?
Bhavana, please. Abraham, sir.
So she has a very high chance of recurring in the abdomen, since we know that the omentectomy also has not been done. And by virtue of her histology, that is the first place where she's expected to recur. And in addition, we can also do a P53 analysis if we want to subsequently, and then plan her again for chemotherapy. If she has already received radiation, that will not be a choice again, but she could again go in for chemotherapy. And depending on the P53 mutation status, we can decide if we need to add something else or not.
Thank you, madam. Thank you all for patient hearing.
So good. Thank you, Dr. Rumana. Then go to your next case, second case, please. Yes, Dr. Santosh Menon sir is with us, and I think we will have to leave early.
I think there's one question, I think, in the chat box.
Yes, sir.
What kind of chemotherapy should be used? We have not discussed about what kind of chemotherapy. The most common chemotherapy which has been used for carcinosarcoma is again usual paclitaxel and carboplatinum combination. Okay, that is used for almost all the gynecological cancers. Combination of paclitaxel and carboplatinum. It has been used for endometrial cancer. It has been used for cervical cancer, ovarian cancer, fallopian tube cancer, and vulval cancer. So paclitaxel and carboplatinum is the main drug for almost all the gynecological cancers, including carcinosarcoma of the uterus. And this is combined with radiotherapy. Now, radiotherapy has been given in various ways. You can either have a sandwich therapy. That means you give 3 cycles of chemotherapy, then you give radiotherapy, and again you give 3 more cycles of chemotherapy. Or some people give concurrent chemoradiation. That is, initially you start with radiotherapy along with single agent cisplatinum or carboplatinum. Once radiotherapy is completed, then you continue with combination of paclitaxel and carboplatinum, remaining 4 to 5 cycles.
You want to hear from Bhavana, please. Dr.
I
Bhavana,
think
please.
Yes. Okay.
Yeah.
Can
Is
you
it
hear me?
3 cycle? Yeah.
Yeah.
3 cycle or 4 cycle, then followed by?
Actually, what Dr. Bafna is saying is something which we also commonly follow. We do a sandwich therapy for most of patients presenting like that, or if a patient has ovarian metastasis, wherever there is a chance of abdominal spread and there is also local radiation required. So there are 2 types of regimes that we follow. One is we give 3 cycles upfront chemotherapy followed by local pelvic radiation followed by chemotherapy. Or we also follow a regime of 4 cycles of upfront chemotherapy, the reverse of POTEC 3, followed by local pelvic radiation. I mean, this especially we do when we are adding brachytherapy, because, if we are giving a sandwich, most of the times the 3 cycles get delayed, because after external radiation also you have to wait for about 2 weeks.
Yeah.
So we modify our treatments depending on what is the extent of radiation the patient will require. And I completely agree with Dr. Bafna regarding the chemotherapy, but some centers, depending on the sarcomatous component, also use ifosfamide in addition to the paclitaxel carboplatin also. But that is again not a standard practice at our center, but yes, that is given as a part of an option treatment, provided the sarcomatous component is higher.
But as we have seen that in case of the carcinosarcoma, the most recurrence occurs in the pelvis, not in the upper abdomen. At first, the pelvic recurrence is more common. What is your experience? As we have seen,
Carcinosarcoma.
yeah.
Are you asking me?
Yes, yes.
Okay. Carcinosarcomas, unlike the endometrioids invariably occur in the pelvis. The carcinosarcomas can occur both in the pelvis and the peritoneum. The serous carcinomas primarily occur in the abdominal cavity, like ovarian.
Yeah.
And they can even
4
metastasis.
cycles of chemotherapy upfront, I think, is tolerated better. So we have been giving 4 cycles of chemotherapy first, followed by radiation.
Yes.
Because I think the tolerance, because after the other regimens, patients usually do not tolerate as well.
Yes. And in addition to that, so we are treating most of our patients with IMRT. So that is also making a difference in terms of tolerance. The bowel is getting spared and the toxicities are much lesser.
Here there is no lymphadenopathic, so can we not, why will we go for the external radiotherapy? Can we not give him the brachytherapy?
So like the GOG 249, like you said, that we could
Yeah.
probably give chemotherapy followed by brachytherapy. See, the reason for me saying, I mean, what was the extent? What were the number of lymph nodes that were
Around
removed?
18 lymph nodes. 18.
18. Okay, so
Yeah.
that is a good number of lymph nodes that is removed. The cervical size lesion, although we cannot, I mean, we have to see 2 things. Are we considering it as a primary cervical lesion?
Yes, as because there is the cervix the growth was mainly in the cervix, and it was subtotal hysterectomy was done, and only the lower part of the cervix, we have not, we didn't get the endometrium. So we think it is cervix, from cervix.
Because I would still think that this is a CA endometrium
Extended to cervix.
carcinosarcoma, yes, because isolated cervical carcinosarcomas are extremely uncommon, and they have to be, the diagnosis has to be made by exclusion. And in this particular case, upfront MRI did show that there was a lesion there.
Yeah.
So yes, so in that case, we would consider her more as a case of a local recurrence. I'm not considering her as a primary cervical tumor.
Yes.
Okay, or a primary endometrial tumor. We are considering it as a recurrence. So in case we are considering it as a recurrence, I would still be more comfortable giving pelvic radiation in a 7 centimeter tumor or 5 or 7 centimeter tumor. Yes, like you said, we could follow the GOG 249 protocol if we didn't have chances of pelvic recurrence. If it was the upfront tumor, we could have given her only chemotherapy followed by local brachytherapy. So that's a very small subset of patients where actually the GOG 249 protocol can be used.
So Bhavna, I want to add with you that to me, I want to go with you. It's Kamal here, that
yes.
taking the risk of missing a carcinosarcoma will be dangerous, because if we are happy to treat it as a recurrence of a cervical cancer and go that, rather than I want to go for a very aggressive tumor like it is a carcinosarcoma of uterus and we give everything. I tell like that, whatever I have, give everything. Even I'm not sure what is going to happen, because I am in favor of not to treat it as a cervical, rather I'm still in favor of considering it as a carcinosarcoma of endometrium and treat it with the 4th cycle. That the 4th cycle that was discussion was going on, there is many centers even use 6 cycles in carcinosarcoma, because they said, well, you treat it like ovarian cancer. So ovarian cancer, the magic number of 6 works. Endometrium 4 works, but when it is a carcinosarcoma, somebody even treat 6 cycles also. And then after, as she was telling, I'm not in favor of giving wall brachytherapy to this patient, because in carcinosarcoma, I should be giving EBRT here because I don't know where the failure will be. So even you this is the small subset with the vaginal brachytherapy, that is a classical disease. And it is that is I think this case cannot be compared with that one.
Yes.
Any comment, Bhavna?
No, I fully agree with you, Dr. Kamal. That is.
Hi, Bhavna, Santosh here.
Yeah, Santosh, how are you?
Yeah, I'm good, sir. Yeah, I just want to say if the epithelial component is serious, we can almost safely say that this is not a cervical practice, because in cervix, you don't get serious carcinomas.
Sir, here Vimentin is positive, sir.
I don't rely too much on single marker, Dr. Shah.
Yeah, also
Put everything in the context. So just Vimentin positivity will not make, because see, this is a carcinosarcoma. There's a transition from epithelial to mesenchymal. So even the epithelial, mesenchymal, everything is going to express Vimentin here. So single marker is not going to make any difference.
Thanks,
I just wanted
Santosh,
to know
for
the
saving
report.
us.
Did the report say how what is the myometrial invasion or cervical wall invasion? I couldn't see that in the report.
yes. Umana, please inform the report. Please show the report of the histopathology report of the cervical stromal invasion.
In final histopathology report, madam,
Yes.
it showed LVSA positive present.
No, wall.
No, wall.
Infiltration into the wall.
There is no comment about infiltration.
Yeah, so that's important both in endometrium and cervix, cervical, because many of the times these carcinosarcomas are present as polyps. So they are not invading the myometrium or not invading the cervical many times. They present as polyps because they are very fast growing tumors. So they grow into the cavity rather going into the wall. So sometimes they may be just a PT1A tumors because they're all within the polyp.
But this one was a big lesion. I think
lesion.
that's what you said, about 5 centimeters or 7 centimeters.
Yeah. So
No,
I'm
ma'am,
not
it is
contesting this. I'm
3
generally saying in carcinosarcomas may many times we just be polyps actually.
Yes.
Yeah.
In this case, MRI scan shows a large tumor involving the cervical stroma. In fact, the entire cervix was replaced by tumor.
Oh, yes, sir.
So all the more reason we should give her pelvic radiation, because the LVI is also positive. So LVI positivity not only puts the patient at a risk of lymph node metastasis, but also at the risk of parametrial involvement as well.
Should we start the second case? You wanna please go the second case start.
Is the screen visible, madam? So I'm now going to start my second case. This patient is a young lady of 27 years, para 2, second gravida. She presented at her 14th week of pregnancy with complaints of unusual abdominal distension. She had her ultrasonogram done at 6 weeks of pregnancy, that is 2 months back, which showed 6 weeks, 4 days of intrauterine pregnancy, and both adnexia were normal. But when she came at 14th week of gestation, her ultrasonogram showed 14 weeks, 4 days of intrauterine pregnancy, right adnexal solid mass 9.7 into 9.5 into 7.8 centimeter with gross ascites. On examination, her echo performance status is 0, no lymphadenopathy. Breast examination revealed normal. On parabdominal examination, there was huge ascites. No mass or uterus could be palpated due to ascites. Gentle pelvic examination was done, which showed ill-defined mass in right adnexal region. So what are the investigations needed for diagnosis and making treatment plan for this case? This is a case of 27-year-old lady with 14 weeks of gestation and a solid mass with ascites.
This lady with 27 years old lady with solid adnexal mass.
With huge ascites.
Yeah, which has appeared suddenly. So most probably you are dealing with malignant germ cell tumor. And most likely it's going to be digeminoma. But the markers for digeminoma, which are non-specific markers, like serum LDH marker and serum CA-125. They are also raised in pregnancy. And sometimes you can have a mixed germ cell tumor, wherein you have a rise in beta HCG and alpha fetoprotein. These markers also are raised in pregnancy. But nevertheless, should have a baseline values of beta HCG, serum LDH, CA-125, and alpha fetoprotein. Because very sizable increase in these markers would guide you for further therapy. So I would like to do all the 4 markers: serum CA-125, LDH, alpha fetoprotein, and serum beta HCG. These are the basic 4 markers which should be done for this particular patient with right adnexal mass and ascites. An MRI scan has been done. I don't know. MRI scan, I think, would throw some more light on the kind of tumor you are dealing with.
Okay, sir.
An MRI scan is safe during pregnancy. So I think you should have an MRI scan also before doing anything else.
Okay. Patient was consulting to a local gynecologist, not in a tertiary center, sir. Okay. Now, ascitic fluid was aspirated and sent for histopathology, sent for cytology and gene Nielsen staining, which revealed no malignant cell, and acid fast bacilli was not found. Our markers, tumor markers are also done, which showed CA-125 was raised 506 unit per ml, CA-99 150.6 unit per ml, LDH and CA were normal, and alpha fetoprotein and beta ECG was not done.
Okay. How about imaging? Any other imaging method has been done?
Sir, no, only ultrasonogram was done. No imaging was, MRI or CT scan was also not done.
Not done. Okay. I think if it's possible, better to do MRI scan.
Yes, sir.
But if it is not possible, then I think you should go ahead with surgical treatment.
Okay.
Any pleural effusion?
No, sir. No
No,
pleural.
sir. No pleural effusion. So with this investigation in hand, what should be our treatment now?
Yeah, she should have laparotomy, definitely. She
Okay.
should have laparotomy, and she's in 2nd trimester of pregnancy. So you must take care to prevent premature labor, premature abortion. So you must take care and involve obstetrician into the plan. Then you can go ahead and do minimum surgical staging, because pregnancy, you cannot do thorough surgical staging. So first thing you have to do a vertical incision and try and remove the right adnexal tumor intact completely. And you can do an infracollic oventectomy. They don't
Remove the tumor and send for frozen section, and then go proceed.
Yeah.
I mean, you might be surprised. There may some benign conditions also may be there. We can't assume that it's malignant.
Yeah, of course.
The ascites, solid tumor. Even after that, sir, it is used ascites with solid tumor.
You can have.
Classically, when you open the tumor, when you open the abdomen, dysumenum has got a classical appearance.
Yes, sir.
Okay, and you will not miss it usually. By looking at the tumor itself, you will know that you are dealing with malignant ovarian tumor.
I mean, you have to do a frozen
section. If you have
section.
a facility for frozen section, there's no harm in doing frozen section. Definitely
Yes.
should go and confirm the diagnosis by frozen section. And do infracollic oventectomy. Don't try and do pelvic node dissection and paraortic node dissection.
Frozen section should be okay, sir. Agree.
Yes.
Sir, if frozen section, paraoperative frozen section reports revealed negative for malignancy, then should staging be done?
And it is available in limited center in frozen section petri disease, sir.
What is the question? I could not get the question. What is the question?
So if frozen section is not available, then you do like Bafna said, you remove the mass, scalping oophorectomy with infracollic oventectomy and explore the abdomen, maybe take some biopsies here and there. You wouldn't do anything very extensive. you'll wait for the final pathology and then we'll take it from there.
Okay, sir. So patient underwent laparotomy on 26th June 2021 in a private hospital. Perioperative findings were huge ascites, right ovarian solid mass was there, measuring 10 into 12 centimeter, no visible surface involvement. Left ovary was apparently normal. No metastatic deposit are found on peritoneum or omentum. So keeping pregnancy alive, right-sided salpingo oophorectomy with total omentectomy was done, and biopsy was taken from left ovarian tissue. So patient is 27-year-old clinically advanced ovarian tumor. Is it justified to do surgery without germ cell marker and advanced imaging? I think it is already discussed. Here is her histopathology report. Histopathology report showed right ovarian tumor, malignant yolk sac tumor, and tissue from left ovary showed suggestive of yolk sac tumor, consistent with metastasis from other ovary. Omentum showed metastatic yolk sac tumor, and right fallopian tube was free of tumor. Peritoneal fluid cytology showed metastatic yolk sac tumor. So final diagnosis is yolk sac tumor with right ovary with metastasis to omentum and opposite ovary. Patient had normal ultrasonogram at 6 weeks of pregnancy and she was asymptomatic that time. But within 2 months, there is advanced stage tumor. So is this usual for yolk sac tumor?
No, not usual at all. Yolk sac tumor during pregnancy is not very common. What we expect is dysgeminoma. That's why I mentioned that sometimes when I have a mixed germ cell tumor, should have a serum alpha fetoprotein marker also done preoperatively. Not only alpha fetoprotein, should also have serum beta HCG marker done preoperatively so that you have a baseline value, so that you can plan your further adjuvant therapy.
No, sir, her
Yeah.
question at 6.
Such a rapidly growing tumor like this, you think of yolk sac tumor only. It can grow very fast.
Yes, sir.
So within 2 months, I think we should have definitely sent yolk sac markers.
Yes, sir.
Sir, this question is for Santosh Menon, sir. We know that Schiller duval bodies are seen in case in yolk sac tumor histopathology report, but here it was missing. So should we?
So Schiller duval will not be seen in every yolk sac. They are characteristic, but they will not be seen in all cases. You can have solid patterns. So yolk sac has about 11, 12, 13, several patterns. So this Schiller duval is seen in the classical pattern or with the reticular, but it's not seen in every case.
Okay, sir. So, sir, as preoperative evaluation not done and surgical staging was not done due to pregnancy, now how patient should be evaluated in postoperatively?
Already you have done a laparotomy. Already you have inspected the abdominal organs, and you found that patient has got metastasis in the opposite ovary also. She has got metastasis in the omentum also. So definitely she is stage 3, at least minimum stage 3A, because there are deposits in the omentum. So she definitely requires adjuvant chemotherapy. The most commonly used chemotherapy would be a combination of bleomycin, etoposide, and cisplatinum. Now, whether we can use it during pregnancy, whether it is safe, I think that is a very, very difficult question to answer, because many studies have shown that you can give combination chemotherapy during second trimester and third trimester, late second trimester and third trimester, and better to give 2 drugs rather than giving 3 drugs. Instead of giving bleomycin, etoposide, and platinum, you can give etoposide and platinum. But I feel there is a risk is there to the fetus. Long-term risk, we don't have good data to show what is the long-term risk to the fetus. But whatever literature is available, I think the chemotherapy can be given during second trimester and third trimester. And this case, will require adjuvant chemotherapy, definitely. If we don't give chemotherapy, she is going to have recurrence within no time. She'll come back to you with a big mass within 3 to 4 weeks. So chemotherapy has to be started as soon as possible, preferably within
Okay.
2 weeks
Okay,
of
sir.
surgery.
Yes, sir.
So may I add something?
Yes.
Yes.
So, like you said, chemotherapy definitely has to be given. So we have experience of giving chemotherapy in a few patients during pregnancy over the last few years. And like you said, normally the chemotherapeutic agents that they say can be given safely are paclitaxel and carboplatin. And since the TIP regime is anyways used as a second line chemotherapy in these drugs, we have used paclitaxel carboplatin even in these patients. And they do fare well because bleomycin and etoposide are the drugs which are not usually recommended in pregnancy. So that is an option that could be used in this patient. This platinum compound remains the same. And taxane also has shown benefit in germ cell tumors. Thank you.
Yes,
Thank
I
you,
would agree
madam.
with you. Definitely, I would agree with you. I would rather prefer a combination of paclitaxel and carboplatinum rather than giving etoposide, which
Yes,
is more dangerous during
Yes.
pregnancy.
Yes, sir.
Thank you, madam. Patient then was referred to a gynecologist who advised some investigations. Postoperative MRI whole abdomen was done, which showed gravid uterus containing a single fetus, no solid or cystic lesion in adnexal region, mild ascites, no lymphadenopathy, no focal lesion in liver. So there is no residual lesion except mild ascites. Tumor markers are here, which was done 10 days after her surgery. Alpha fetoprotein was slightly raised 58.54 nanogram per ml. Beta HCG is 32,308 milli-international per unit per ml, which corresponds to her 15-week gestation. CA and LDH was normal. Her pregnancy profile sonology was also normal, which showed 15 weeks, 3 days pregnancy, single live fetus. Minimal ascites was there. So she is now 15-week pregnancy. I think discussion has already occurred. Now patient should get chemotherapy in this 15-week of pregnancy. Answer. Okay.
And patient is keen to continue pregnancy?
Yes.
Patient is, yes, she wants to eagerly to continue her pregnancy.
Has she had chemo or she has not yet had chemo?
Sir, I'm proceeding. What may be the adverse effect if BP schedule is done on pregnancy, or what will be its effect on pregnancy, fetus, or future child? What may be the adverse effects?
I think most important, any chemotherapy during pregnancy is going to cause intrauterine growth retardation. That is sure. So apart from that, I think we should not expect any problem during pregnancy. And patient is also prone for premature delivery, premature birth. IUGR and preterm delivery are very common after giving chemotherapy. I never used BEP during pregnancy in the last 32 years. Pregnancy, we have used paclitaxel and carboplatinum, but I have not used BEP. So I can't definitely say whether BEP is safe or not. I don't have enough data. So I would like to use here a combination of paclitaxel and carboplatinum, which is much more simpler to give. Just one day chemotherapy given once in 3 weeks. And the question is how many cycles to be given now?
Yes, sir.
Yeah. So normally I think germ cell tumors are very sensitive tumors. So I think 3 cycles should be enough. 3 or 4 cycles should be enough. Should not give 6 cycles like epithelial ovarian tumor. I think 3 cycles or 4 cycles should be enough. And you keep on monitoring the serum HCG and alpha fetoprotein levels to see that they are not rising, because some amount of rise in CA in alpha fetoprotein and LDH is normal during pregnancy. So, but you should not allow them to rise beyond certain limit. So I think 3 cycles to 4 cycles of combination of paclitaxel and carboplatin given once in 3 weeks should be good for this case.
Okay, sir. Sir, as there is hemodilution during pregnancy, has it any effect on dose of chemotherapy? Dose should be increased or same as without pregnancy?
So normally paclitaxel is given depending on the body surface area. So I think same, I think formula would hold good for this pregnancy also. And carboplatinum is calculated according to area under curve. So I think I would not like to change the policy. Same dose, almost same dose should be given during pregnancy also. I'm not very sure, but I'm not very sure because I'm not sure.
Dr. Bhavna, Abraham,
yes.
okay? Yeah.
We also have not done any kind of dose reduction for the patients that we've treated with paclitaxel carboplatin. Another thing that I would like to add on to this is, especially when the patient is in the third trimester. So normally we prefer to give the chemotherapy 2-3 weeks before the expected date or whenever the patient is planned for induction. That is because of risk of maternal and fetal neutropenias. Other than that, it is very safely tolerated. And I am not sure about the number of cycles to give because we have given 6 because the 3 cycles or the 4 cycles of BP comes from the dose of bleomycin that is given on day 1, day 8 and day 15. So that kind of becomes, I would not say dose dense, but then I don't know if that amount of dose compensates, carboplatin can compensate for that or not. But since the experience is, I think we all have to go by our individual experiences. So we prefer to give 6 cycles of chemotherapy in these patients. In fact, we've even done that we've given 3 to 4 cycles, and then after the patient has delivered, we've continued with the rest of the cycles.
Okay, madam. Thank you.
I think in this case, the patient is 15 weeks pregnant.
Yes,
so
sir.
3 cycles would get over in no time. It will get
Yes.
over in 2 months, 2.5 months time.
Yes.
That means she would be 15 weeks plus another 10 weeks, 25 weeks.
Yeah.
Still long way to go.
Have a long.
Still long way to go for term delivery. So I think I feel 4 cycles should be enough because germ cell tumors, especially yolk sac tumor, are highly sensitive tumor. Unfortunately, here we cannot use tumor markers.
Yes.
So exactly I cannot say, but I feel the 4 cycles should be adequate. If you try to give more cycles, 6 cycles, then there is more risk of developing IUGR and more risk of having preterm labor because you have to go a long way still. It's just 15 weeks.
Okay, sir.
I think you have to have an individualized approach.
I have a
do proper
question. Why-
counseling and you have to have individualized approach.
So can't we use alpha fetoprotein as a marker? We can't in the pregnancy also? I
For
mean,
pregnancy also it can be used but some level of alpha fetoprotein is always there in pregnancy, produced by the fetus.
yes, but then what would be the usual levels that we would expect around this time?
I think there is no fixed level, but there is some cutoff with it, which I don't
Hundreds,
remember.
would it be in hundreds or?
I'm not very sure. I think I have to look at the
Because,
literature exactly. I don't have the
Because in
exact
that
values.
case, yes, it could guide us in a way. If it is markedly raised, maybe still we could use it as a
No,
sum.
I think Dr. Bhavna, I think the values, no, I think they are given in a range, and you have a very large range. Let's say maybe from 30 to 300.
Okay.
So you have a very wide range of values, normal values during pregnancy.
Okay.
So I think some amount of adjustment has to be done based on the values.
Earlier, a comment was made that alpha fetoprotein level of 57 was that's elevated level. So I don't think we can say that in pregnancy. 57 seems to be might be pregnancy related.
Yes. But it was after immediately after surgery, sir. Her alpha fetoprotein was 53 or 57. It was immediately after surgery, sir.
Yeah, it could be due to pregnancy itself.
Yes.
I mean, we can't say it is elevated
Yes.
in pregnancy.
Next one.
Tumor board decision were chemotherapy with etoposide and cisplatin, 3-weekly schedule. Patient had already received 3 cycles of chemotherapy. Now, what should be her follow-up protocol during pregnancy and after delivery?
think this patient good. She received 3 cycles of etoposide and platinum without bleomycin. So bleomycin is not very mandatory for germ cell tumor. So study has been done with BEP regimen comparing etoposide and platinum. But when you are using only etoposide and platinum, probably you have to give 4 cycles instead of 3 cycles. So 4 cycles of EP regimen is probably equivalent to 3 cycles of BEP. But here, since I think we don't have any residual disease left behind in the pregnancy, in the abdomen, there is no residual disease left behind, and alpha fetoprotein values are not very high. So I think 3 cycles is good enough for this case. 3 cycles of EP is good enough. So you must continue to do weekly alpha fetoprotein. Weekly alpha fetoprotein. I don't expect any recurrence for this case because recurrence
Why
is
not?
going to be
Why not? Why you
no,
not?
because you have very good chance of cure, almost
No, sir.
100% cure
There
rate.
was involvement of another ovary. Only the tissue biopsy was taken from that ovary.
Okay. No, but even then, the germ cell tumor's chance of cure is more than 90%.
Yes, sir. But how should we treat these patients? We
No, you have to have a follow-up.
Yes. Now, sir, we terminate her up to the continue the pregnancy up to her 40 weeks, or we terminate her pregnancy up to the young maturity of the fetus.
No, during pregnancy, if alpha fetoprotein level rises, which is very, very unlikely. I don't expect it. After giving 3 cycles of etoposide and platinum, I don't know what happened to this case, but I don't expect the levels to rise. If it rises, then that means you are dealing with a very bad disease. Okay, because not all the patients with yolk sac tumor are going to get cured with BEP. There are some 10% of patients who do not respond to chemotherapy. So probably she comes under the category of resistant to chemotherapy. And since you are saying that stellar dual bodies were absent, we have seen that stellar dual bodies are absent in patients who do not have a rise in alpha fetoprotein, especially in recurrent yolk sac tumors. We have seen recurrent yolk sac tumors where beta serum alpha fetoprotein levels are normal, and stellar dual bodies are also not seen. So I don't know. I think this patient I don't expect recurrence, but if recurrence occurs, the prognosis is going to be very bad, and you should not allow the pregnancy to continue. You have to treat them aggressively.
Continue up to 34 weeks or 40 weeks.
No, I don't think so, because these tumors are very rapidly growing tumors. You can wait for 1 week or 2 weeks, maximum 3 weeks. You're going to wait for a longer time. The tumor is going to grow very aggressively.
Yes.
Yolk sac tumor grows very, very rapidly.
Yeah.
So you can have a window period of, say, 2 weeks or 3 weeks, but not more than 3 weeks.
Okay, sir. If alpha fetoprotein level rises, is this if P level rise only indicate recurrence, or we should do some MRI or advanced imaging?
No, you should do MRI scan also, because minor rise could be due to pregnancy itself.
Yes.
So you should do MRI scanning also. If MRI scan shows some solid tumor, only then you must worry. The MRI scan is normal, then I don't think you have to worry at all. The value of alpha fetoprotein is not very high.
Okay, sir. Should we do compression surgery during her termination, that is cesarean section, or after delivery?
No, if the patient is normal, there is MRI scan is normal, you don't have to do anything else.
So she has the malignancy in other ovary during primary surgery. Even after that.
Pardon?
So she has the malignancy in other ovary during her primary surgery. And
yeah, I know. I don't know whether the deposit was removed completely or not.
It is
the left ovary.
It is the microscopic deposit, right?
No, sir.
The biopsy was done.
Biopsy was taken, sir.
Yeah, so it was only a microscopic disease.
No, sir, it was metastasis.
Apparently healthy. It was written in the operation note. Apparently healthy.
So if you look behind apparently healthy ovary, there's no need to remove it.
No, sir. As because there is a metastasis in the opposite ovary. Even after that, yeah. And
Even
also
then, I think
the metastasis.
even
There
if
is
you have
no-
metastasis in the opposite ovary, the
Yes.
metastatic deposit has been removed, the markers have become normal. There's no need to remove the opposite ovary and the uterus. Should have a conservative approach. For all germ cell tumors, you should have a conservative fertility sparing approach.
in stage 3 disease after completion of family.
No, after completion of family, probably again we must think about this young patient, 27 years old patient. If the ovary is looking normal during cesarean section, you can still preserve it because hormonal function also is very important. If ovary is looking suspicious, then I think you should remove the ovary. If ovary is looking normal, I think you should preserve the ovary.
Okay, what is your comment? Okay.
This is not there, I think.
No,
Is it there?
it's there. Okay.
Yeah. I love the discussion, and I think it just reflects that we don't take care of a lot of people with malignancies in pregnancy, so we don't have a sort of bulk standard of care. I totally agree with what the management of this patient was. I mean, I think that 3 cycles of chemotherapy is adequate. And I'm sorry, what was the other question?
No, well, can she remove for completion surgery during her termination of pregnancy?
Well,
As-
you know, oh yeah. I mean, I think with germ cell tumors, you're hoping that you cure her, and it's a highly sensitive, chemosensitive
But
disease.
it's a sac tumor, and opposite ovary was involved with the tumor.
Yeah,
Or omentum was also involved.
I know. I mean, you could do a so your options are, if her tumor markers are completely negative and her imaging studies are negative, you could follow her because again, it's an exquisitely, you know, your tumor markers are very much kind of follow and track the malignancies. That's one option. The other option would be to do a diagnostic laparoscopy and look and take biopsies and washings, especially if she's interested in further fertility. And your final option is to do completion surgery. So just including her in your decision tree. Finally, I understand there's many challenges for many of the ladies in Bangladesh in terms of where they are economically, family, support, location, and so forth. If you have a concern that this patient may be lost, you know, that might be a reason to be more aggressive, where you have her in your clutches and you want to do a completion surgery. If she's someone that you can see and monitor very carefully, those are the options to discuss. I'm curious what other people think.
She had already another baby. Abraham sir, what is your comment?
Yeah, like I would agree. I mean, if the tumor markers are negative and the imaging is negative, we could be conservative. And if you're suspicious, we would have to go ahead and proceed. So
No,
I
sir,
don't think
sir, she has already one baby, and during her termination of pregnancy or after that, and it has already a stage 3 disease, and it is rapidly growing disease. Even after that,
we need to discuss with and counsel the patient and take a joint decision whether she wants to go in for, you know, it depends, I suppose, on your counseling also. If you frighten her, she will say remove everything.
no, I think Dr. Amita Maheshwari, madam, are you here, madam? No, she is not here. She was here. Okay. So what is our final decision? We can continue. We can her ovary can be. We can keep her ovary as usual, even if it is normal and all her alpha fetoprotein, everything was normal. We can follow up her. Yeah, after termination of pregnancy.
Yes.
I think with the imaging modalities that we have, most of the centers are not going in for completion surgery.
Yes, sir. Yes. Oh, that's yeah. Next. Mona, just fine. Mona?
Am I audible, madam?
Yes, just fine.
Should adjuvant therapy be given after completion therapy? If completion surgery is done, then again adjuvant chemotherapy should be done or not?
No. Answer is no.
Only the follow-up. Already discussed.
Okay. It is a 20-week anomaly scan after getting chemotherapy, which showed no gross fetal anomaly. And now fetus is 24-week and with good condition. So hope for cure mother and healthy newborn. Thank you.
Now, Dr. Sharif Nazmunar, I request Sharif Nazmunar to present your case. Nazmunar, please.
Am I audible, madam?
Yes. There are some questions in the chat box. All the faculties has requested to answer the questions. Sir, please.
No, I need to leave in about 20 minutes.
Okay, sir.
So I have another- Thank you.
Sharif Nazmunar, please share your screen.
Honorable Chairperson, respected faculties.
Your screen is not shared.
Yes, madam. Am I sharing, madam? Sharing, madam. Is the screen visible, madam?
Yes. Slideshow to the slideshow. Yes.
Honorable Chairperson, respected faculties, and my colleagues, Assalamu alaikum. I'm Dr. Sharif Nazmunar and presenting my case. Mrs. X, 58 years, para 1, living child 1, normotensive, non-diabetic lady, presented with postmenopausal bleeding for 2 months and lower abdominal pain for 1 month. She has no personal and family history of breast, ovary, and colon cancer. With this complaint, she consulted with a gynecologist in a private center. TBS done, and it revealed thickened echogenic endometrium 29.5 millimeter and shows hypervascularity. Pap smear done, and it shows negative for intraepithelial lesion or malignancy. The question is, what should be done next? Sir.
Any ascites?
No.
Really, jure bolen.
No, sir.
No ascites. So it's only a uterine growth. I would do a pipal biopsy. And if that is negative, I would do a hysteroscopy. But if that gives an answer, then you could go from there.
Where the patient treatment, where the patient got the treatment?
Patient treated in a private center.
Which center? In Dhaka city or in
In Dhaka city. In Dhaka city and tertiary level private hospital.
Okay, next.
Her total abdominal hysterectomy and bilateral salpingo-oophorectomy done in a private setting, and paraoperative findings, there was no abnormality in uterus, cervix, or adnexa in gross appearance, and cut section showed endometrium thickened.
So she didn't have a pre-op biopsy?
Biopsy without
No, sir.
biopsy.
There was no, without endometrial and cervical evaluation, operation was done.
Okay.
What is the histopath?
Histopathology report shows papillary variant endometrial adenocarcinoma, endometrial type grade 1, and less than 50% myometrial invasion. Myometrial thickness was 10 millimeters. My question is, does she need adjuvant therapy based on clinical, paraoperative, and histopathological findings?
Was LVI reported?
Sir, given?
LBSI, is there any report of LBSI?
No, no.
It's a grade 1 endometrioid
Grade 1.
with less than 50% myometrial invasion.
Yes, please.
No
LVSI
comment on
report,
LVSI.
LVSI was negative.
And there's no obvious growth as such, just thickened endometrium.
Thickened endometrium, just thickened endometrium.
And cervix was normal.
Yes,
Cervix
yes,
and ovaries normal.
obviously normal. Sir. Paraparty findings was normal.
Okay, she needs post-op imaging. Has she had a CT scan or MRI scan?
Before preoperative CT scan or MRI not done.
Post-op?
Postoperative.
Postoperative, yes, sir.
Next.
As the patient is unstaged, how she should be evaluated? Patient, this question is already answered, sir. She was referred to an oncologist, CT scan of whole abdomen normal, and tumor marker CA125 done, which was also normal. Question is, what should be done next?
This patient has got stage 1A, grade 1 tumor.
Yes, sir.
Only thing is that LVSI has not been commented upon.
Yes, not commented.
Yeah, if LVSI is absent, then she does not require any adjuvant therapy because she belongs to low risk category. Stage 1A, grade 1 tumor, no LVSI, no treatment is required, no adjuvant treatment is required.
Yes,
So I think you must have a good pathological examination and try and get the correct pathology. Because we don't have any comment on the LVSI, so it's going to be very difficult to answer. Or the second best option I would suggest is she can have a brachytherapy because the tumor invasion is less than 50%.
50%, less than 50%.
50%. So unless she has got multifocal LVSI, okay,
Yes.
she does not require any therapy. Or at the most, for focal LVSI, you can give a brachytherapy alone.
Dr. Bhavna, if this type of patient in your center, what will you do?
Like Dr. Bhavna said, LVI is the most important prognostic factor in this patient.
Yes.
Which is going to direct our adjuvant treatment. So
Yeah.
we usually ask for the blocks for review and see if there is substantial LVI present.
Yeah.
If it is, then we go ahead with wall brachy. If not, we keep the patient on follow-up. And sorry, I missed the initial part of the history. What is the age of the patient?
Age of the patient was 58 years.
Below 60.
Yes, madam. Slide review done and immunohistochemistry done, and it showed endometrioid adenocarcinoma grade 1, ERPR negative.
Why did you ask for an immunohistochemistry in a grade 1 endometrioid?
There was no need to do ER and PR.
Yeah.
But it was done here, and unfortunately, we found it negative. Most of the endometrioid cancers are ER, PR positive.
Positive, yeah.
So now it's become complicated now.
Yes.
All the more reason we need the review, pathology review.
Yeah. Next.
Question. Does she need adjuvant therapy?
She first needs pathology review.
Yes. Whether P53 and MMR immunohistochemistry should be done in every cases of endometrial carcinoma? Madam.
Yeah, according to the recent guidelines given by the International Society of Pathologists and European Society of Gynecological Oncology, all the patients with endometrial cancer, irrespective of the risk, they should have MMR gene evaluated. That means you must look for MMR deficiency. MMR deficient gene is an hallmark, is a marker for endometrioid cancer. So this particular patient, because it is ER and PR negative, and because the pathology is endometrioid, I think you should, if possible, you should do MMR gene assay, ISC. So if it is endometrioid cancer, she should have MMR deficiency. So MMR deficiency ISC is done using 4 proteins. We have 4 standard panel proteins, MSH, PSM, now I don't remember exactly. So you have panel of 4 proteins. So if MMR is deficient, then it is a marker for endometrioid cancer. Okay, and apart from MMR deficiency, if it is possible, you can do P53 marker also and pole mutation also. Pole mutation is very, very difficult to do it. Very, very difficult. We don't do it routinely. MMR deficiency and P53 are done widely, but pole mutation is not done everywhere. So I think this case, at least you should do MMR deficiency test.
Dr. Bhavna, do you do this routinely in your practice? Dr. Bhavna?
Yes, like so said, we are doing IHC markers of P53 and MMR. That is the 4-panel IHC marker. And depending on the positivity, then we go in for further testing. So normally for stage 1, grade 1 endometrioid, we are not going in for molecular testing as such, unless it's a grade 3 endometrioid, which is more common for Lynch syndrome. But this case is different because you've already done an IHC, which is showing an ER/PR negative, which is unusual for an endometrioid.
Yeah.
So definitely this warrants more of pathological review and a detailed IHC. Poly mutation is not being done. That's a molecular test, but this is the basic IHC panel which is being followed.
But in grade 2, do not do the P53 or
See,
MMR?
actually, the recommendation is to do it in all patients,
All
but
patients, yeah.
but in at least in our center, and I don't think in most of the centers in India it is being done for every patient. We are doing it in relatively younger patients, on in older patients with a family history, and MSI testing, or if it's a grade 3 endometrioid, or there is anything suggestive of an MSI. If they're saying it's a endometrioid high grade histology, they ask us if MSI testing should be done. If in recurrent setting, we are routinely doing IHC for MMR and P53. But in upfront setting, we are doing it mainly for younger group of patients who are non-endometrioid histology, or patients who are high-grade endometrioid. We are not doing it for grade 1, stage 1 endometrioid disease.
Grade 2, is it?
Grade 2, again, like I said, we are taking into account other things, the age of the patient also.
Yeah. Okay.
And I mean, most of the centers are following the policy of IHC, but I think we are basically going by the logistics also.
Yeah.
But this is the basic standard panel that is being done.
So I have a comment question to Bhavna.
Yes.
So if logistic is not an issue, so
Yes.
what will as Dr. Bhavna was telling that Bhavna was telling about the MMR, what is the iron? Pole is tough, but P53 is easily doable at many places.
Yes.
So what is the recent recommendation for using P53 mutation? Because MMR is giving some clue, but P53 changes the total treatment.
Yes. See,
and that is identifying the high risk group among the low risk group.
Yes.
So even the pole and MMR all are important, but I think in clinical practice, main game changer is the P53.
Yes, it's the P53.
So there was a question that when should we do the P53? Who is the ideal candidate to do P53? Forget about logistics and everything.
All non-endometrioid histologies and grade 3 histologies should have a P53 mutational IHC.
What about grade 2?
Grade 2 is the zone of dilemma, gray zone.
According to the recent guidelines given by European Society of Gynecology, grade 1 and grade 2 have been pooled together. They are called as low grade. So you have only 2 grades, low grade and high grade.
Yes,
Grade 1 and grade 2 is low grade, and grade 3 is high grade. So if at all you are going to use P53 marker and MMR deficiency and pole mutation, for low risk, you can avoid all these markers. But for intermediate risk group, intermediate high risk group, and advanced cancer, you should do all the 3 markers if it is possible to do it. Because sometimes what happens is that you can have pole mutation in grade 3 tumors, which are confined to the uterus. Then you can avoid adjuvant radiotherapy and chemotherapy.
Sir, I would have a little bit of difference of opinion on that because we are not sure as of, I mean, it is postulated that perhaps they will not require any adjuvant treatment, but all the evidence that we have so far for patients with polymutations, all of them did have adjuvant treatment. This is basically from the POTEC 3. So that part we are not sure of. And I think a lot of people feel that we can do away with pol mutation as of now, because that will not perhaps add on to anything. The de-escalation part has to be proven as yet. But other than that, yes, I completely agree that the P53 and the MSI, the MMR IHC is a must for anything which is high intermediate and above.
Yeah.
That is non-endometrioid and all non-endometrioid histologies.
So, Bhavna, I want to add that probably we are waiting for the prospective trial outcome with this, because whatever is conclusive is P53 is for the treatment decision. And POL is giving us the prognostic idea, and MMR is also. So probably, I mean, the clinical decision yet to be based on POL mutation, but we can give a clue of a good prognosis, Dr. Bhavna. I want to say that because the last paper that was published with this combined ESGO and ESMO, I think combined, they recommended the decision to change the treatment on P53, but yet I think POL is, we are waiting for the prospective study outcome. If I'm not wrong.
Yes, I think I agree with you.
The other thing, sorry, I've just been thinking about this case. This was an ER/PR negative. There are a small set of patients, a subset of patients these days we are seeing turn out to be undifferentiated carcinomas, even in early stage endometrioid. We've had 2 patients where they went and looked back to the histologies which were initially reported as grade 1 endometrioid. And they looked again and they realized that on sections that they were undifferentiated cancer. So like I would say for the pathologist also, Dr. Menon is not there, otherwise we would have asked him. You could have a subset of patients who would be undifferentiated endometrioid carcinomas, and these behave aggressively, especially in this patient where ER/PR is negative.
Can I proceed, madam?
Yeah.
According to the plan of oncologist, she received EBRT 5000 centigrade by 25 fraction from April to May of this year, and 2 insertion of high-dose rate brachytherapy from 23rd May 2021 to 13th May 2021. She was uneventful for 1 month, and then she developed abdominal pain, anorexia, nausea, and vomiting. Her ultrasonography of whole abdomen done, and it revealed multiple echogenic SOLs in the liver, suggestive of secondaries and mild ascites. And CT scan of whole abdomen done, and it showed multiple retroperitoneal soft tissue masses occupying right hypochondriac region of abdomen with possible infiltration to antrum of the stomach, intestinal loops, and mesentery, diffuse SOLs in the liver, larger ones 6 into 4 centimeter, suggestive of secondary metastasis. Asymptomatic thickening of mesentery and peritoneum, possibly peritonitis carcinomatosa. What should be done next?
Obviously, I think the first diagnosis has to be reviewed, because endometrioid cancer, ER/PR negative don't normally tally. They don't go hand in hand. So I've seen many patients with endometrioid cancers, grade 1 tumor. Sometimes 90% do well, but 10% they behave aggressively. What are these 10% of patients who belong to grade 1 tumor, but still they have behave aggressively? So probably the molecular study would throw some light here. So probably in this case, if you have done MMR deficiency marker, IHC panel, if you had done, then probably we would have known whether patient had endometrioid cancer or not.
Yes.
Okay, now since that she has behaved very aggressively, that means we are dealing with a very aggressive cancer here, and the tumor is already spread to the liver. So now the question is what is the plan of treatment? I think the treatment is going to be mainly palliative chemotherapy, because once the tumor is spread to the liver so rapidly, she is not going to do well. So you must plan for palliative chemotherapy. The chemotherapy of choice would be a combination of paclitaxel and carboplatinum. Okay, and then probably we can add immunotherapy also later. But immunotherapy with pembrolizumab and lenvatinib, we don't have a big experience here because they are a very expensive drug, and it is beyond the reach of many people, including who belong to upper class. Very few people can afford, at least in India. Immunotherapy is very difficult. So in this case, I would go with palliative chemotherapy with a combination of paclitaxel and carboplatinum.
And we can't use hormonal because it's ER/PR negative. So I suppose we are just stuck. Yeah, immunotherapy and chemotherapy would be the treatment for this patient. Sorry, I have to leave now. Thank you, everybody.
Thank you, sir.
Thank you.
Thank you very much. Dr. Bhavna, what is your comment?
Same as Dr. Bafna and Dr. Abraham, that definitely this is a systemic spread. And I think what was going on in everybody's mind was the ER/PR negativity in a stage 1, grade 1 endometrioid carcinoma. So I would go in for FNAC and cell block, both from the liver lesion and a review of the previous slide, including an IHC P53. And I would also want to get a HER2 new mutation, HER2 new status for deciding whether she can be given any Herceptin or not. Usually PD-L1 inhibitors are given with they are seen with this MMR deficiency. So the IHC is the one that is going to guide us what we have to do next. And then we go in for further testing of PD-L1 and HER2 new for deciding about immunotherapy, whether it is Herceptin or pembrolizumab PD-L1 inhibitors, along with paclitaxel carboplatin. But again, the benefit of adding immunotherapy is very limited, and we should know it's only adding on to 2.5 months of PFS benefit.
Yes.
So that also has to be decided. The cost-effective analysis has to be done before deciding the treatment.
Next.
FNAC from liver as well done, and it suggests possible for malignant cell, suggestive of metastatic adenocarcinoma. Endoscopy and colonoscopy was normal. Tumor marker done, and CEA beta ECG was normal. CA125 elevated 391 unit per ml, and alpha fetoprotein was highly raised, more than 52,000 nanogram per ml. What may be the cause of
My question is, why did you ask for AP?
For multiple as because it was the endometrioid type, grade on less than 50% myometrial invasion. Even she didn't have the need of any adjuvant treatment. Even after that, she received EBRT and brachytherapy. So why we have got this multiple SOL in the liver? Whether that is the primary in the liver, to exclude that, we have advised to have the alpha fetoprotein. Next, maybe.
Question is answered. Then patient was placed in tumor board. Tumor board decision was ultrasonograph or CT scan guided core biopsy from liver mets, followed by histopathology and immunohistochemistry, P53 and MMR of endometrial specimen. Ultrasound-guided core biopsy of liver tissue shows necrotic metastatic adenocarcinoma, but immunohistochemistry from liver tissue could not done due to necrotic tissue. Immunohistochemistry from previous endometrial block done, and it showed endometrial adenocarcinoma, endometrioid type grade 1, P53 negative, and MSI MMR showed PMS2 negative, but MSH2, MSH6, MLH1 was positive.
Next total we are
Yeah.
done. Dr. Bhavna.
That should be the next one.
Okay, so she should go in for molecular testing.
Yes.
Yes, for Lynch syndrome. And she should also be simultaneously, because alpha fetoprotein is very high.
Yes.
And that is something which should not be associated with liver metastasis alone.
Yes.
We are probably dealing with something else also. And if we look at it and if we are suspecting a Lynch in this, definitely she could be harboring a second malignancy as well.
Yeah.
So the two differentials in these patients are, one is metastasis from endometrium. Second is having another primary, for which we should look at.
Why not the second primary?
It could be. If we are having this panel of IHC, we should go in for molecular testing for Lynch syndrome.
Yeah.
Yes, and if proven, then definitely there is also a chance of a second malignancy in this patient. And third possibility, even if IHC was negative in a stage 1 grade 1 endometrioid carcinoma, we could still have a second malignancy without association with Lynch. That could be a third, but I would put it way down the list.
Bhavna sir.
This one is a very tricky case because alpha fetoprotein levels are extremely high.
Yes, sir.
And you don't expect yolk sac tumor at this age. She is 58 years old.
Yes, sir.
So 58 years old, having a second primary originating from the ovary is, I think, very rare. But since the alpha fetoprotein values are very high, you must consider yolk sac tumor also. And whatever it is, whether it is yolk sac tumor or whether it is an endometrial cancer, which is metastasized to the liver, I think chemotherapy, paclitaxel and carboplatinum should help her. If it is germ cell tumor, if it is yolk sac tumor, definitely a very good chance of having remission. If patient has got a yolk sac tumor of the ovary, but if the patient has got primary endometrioid cancer with metastasis to liver, then I think we are going to manage only with palliative intent. But this is very unusual picture, very unusual. I never seen a patient with endometrioid cancer recurring so fast. Very difficult to explain.
AK, are you here? AK?
Yes, very interesting. Again, I love the conversation. I would say that I do question the primary diagnosis with this information. You wonder whether there was a segment of this tumor that was de-differentiated. So you might have, in general, a grade 1, but there's a clone within that group. I wonder what the measurement was of this primary tumor. So what I would say about the issue with the alpha fetoprotein is that in a de-differentiated carcinoma, endometrioid carcinoma, you can see de-differentiation that leads to very strange and bizarre cell types, sarcomatous changes. I've even seen rhabdomyoblastic sarcomatous changes and so forth. So I would probably keep it simple and assume this is all the same thing, Occam's razor and all, and that you're dealing with a profoundly de-differentiated tumor, and that's the clone that recurred very, very quickly. My only comment about the issue of using immunotherapy, at least in the United States, it's FDA approved for second line, not first line, after the use of chemotherapy. While potentially she does have a terrible, devastating disease that will be chemo insensitive, that would be the standard thing to try first before going to immunotherapy. Yeah.
Anita ma'am, are you here? I think she's here. Okay, so what will be the final her treatment? what should we, different times she has the review her slides and ISC done 2 times and everything, and the liver SL core biopsy done 2 times, there was necrotic tissue. And what should be the next treatment plan? Should we treat her like a liver, the primary, second primary? How will you treat her?
Are her liver function tests normal?
Yes,
Yes.
yes, ma'am.
No, I don't think it is looking like liver primary. If you look at the picture,
Yes.
MRI picture,
Yes.
it's looking like a metastatic disease.
Sir, why is her AFP so high?
We could have a triphasic scan for her. See the status of the liver, or biphasic, sorry.
Treatment for similar function.
According to the tumor board, chemotherapy by oxaliplatin and tablet capecitabine. Accordingly, patient already received first cycle chemotherapy on 23rd August 2021, and next schedule will be 13th September 2021. And the patient is now asymptomatic and doing well.
So this chemotherapy was planned keeping in mind the liver as a primary.
Yeah, this treatment, it was treated in outside, keeping in mind it's liver primary.
Maybe one can monitor the alpha fetoprotein levels prior to every cycle of chemotherapy.
Yes, I think so. Next, Millie.
This is all for this case. And now patient is going through second cycle of chemotherapy. Yes, madam. Thank you. Thank you all.
Oxaliplatin dose is okay, 450 mg. Looks too high to me.
Sir, her alpha fetoprotein probably it was not done because the patient was treated outside. Is that on telephone?
No, I'm asking you the dose of oxaliplatin.
We don't know. What is the dose?
450 mg.
Milli?
Looks high, looks very high.
Yeah.
450 milligram.
Yeah.
Yes, there is something wrong there.
It looks very high to me.
Yes, I think it's wrongly typed, sir.
Wrongly typed.
Maybe.
Sorry, sir. Oxaliplatin 100. And the capecitabine is 50 milligram, 500 milligram. Type to during discharge certificate, madam, oxaliplatin was written 450 milligram, and the capecitabine written 500 milligram.
It was wrongly typed. Right? Yeah.
Yes, ma'am.
Okay, I think we have another case, but it is we are for 2 hours. I think we should conclude now.
Thank you, sir. Thank you, madam.
Thank you.
Thank you, sir. Thank you very much. But before the ending, I would like to thank all the participants, all the faculties. We have too many faculties today, and we are very much happy, and we are very much grateful to all the panelists, all the faculties and participants. Before that, before ending the session, I would like to request our president of our oncology club, Professor Dr. M.A. Haisa, to give her comment and conclude the sessions. And Mahfuz, please show the poll winners of the yesterday last session. Sir, please. These are the poll winners. Dr. Lutfa Begum, I think she's from Dhaka Medical College. Afroza Khanu, this is also National Cancer Institute, and Munju Manan, she is also from National Cancer Institute. Sir, please.
Okay. Thank you, Dr. Sahana. I hope we had a very nice discussed today. All the cases were very complicated. I could understand. All the faculties have taken the pain, particularly Dr. Bafna and Pabna, and Abraham from Oman. And also AK joined today. Hopefully, we had a nice discussion and nice. So I have nothing to comment on this. Everything is okay. Thank you all very much.
Thank you, sir. Thank you. Thank you, Dr. Bapna sir and AK. Thank you very much. You're a long time with us after a long gap.
Thank you. Thank you, everyone.
Hello, Catherine. How are you? How is your father?
Thank you